Good morning, folks. We're at Circuit World, and he's just laughing so hard he can't open his program. I'm Dr. Whaley, and this is Northside Georgia Cancer Specialist, Northside Hospital Cancer Institute, and we are all a little bit nuts here this morning. There's a 24-hour road race going on behind me here. I used to be the doctor to Sports Car Club of America, and I pulled Paul Newman out of a wreck about 40 years ago, and everything in the cockpit was digital. Now you look over here, and they got a TV screen, and they got a bunch of digital things. Look like an airplane cockpit.
Got all kinds of buttons on there.
They had 6 buttons on the steering wheel. There used to not be anything with steering wheel except steering wheel. And I don't know what those buttons are. I think they might be in place of the gear shift and could change the gears, because I don't see him dropping his hand down to do that. So they've taken a lot of the driving out of this thing, and it's like a cockpit. But anyway, it's a beautiful day out there, and we're getting ready to do a few questions. Now, you want to say something?
Yes, I do. Good morning. Welcome to Ask the Doc with Dr. William Whaley. And again, Georgia Cancer Specialist, Northside Cancer Institute. We always have 2 great questions. Dr. Tidman is off. He's our world traveler of the week.
He is hang gliding in Switzerland this morning. It's actually afternoon there now.
He's hang gliding in Switzerland.
Yes, he's hang gliding below somebody that knows how to hang glide. He's hanging from a harness.
Hanging from a hang glider.
Harness underneath the guy hang gliding. Now, he is not taking his life in his hands. He's just being a little foolhardy, because that's a relatively safe thing if you know what you're doing. Now, if you're just learning, I think I wouldn't do it.
Anyhow, Dr. Tidman's not with us, and that is one of our medical pieces of advice for today. But we do have always Dr. William Whaley with 2 great questions.
So we don't get any jokes today because Ray's not here.
I may throw one in, but you told me one week when I told a joke, you said they don't pay for me to tell jokes.
Yeah,
so I'm
they
not
don't.
Going to.
No, yeah.
You know, one thing about our questions, and I want to say this to the viewers, thank you so much, because this is really, I'll tell you what, they're turning into paragraphs.
Well, this one here, yeah.
But we have people that are watching.
Well, this is a return.
They're giving us updates,
yeah.
Right?
Yeah. The funny thing about this is that I think we are guilty sometimes of making people think that there is a magic bullet. The host here has always looked for a quick fix diet, like a B12 shot or something that would help him lose weight rapidly without having to not eat anything and exercise for an hour a day. And if we were to change the camera, you would see a big bag of almonds over here, which people tell you are good for you. Almonds have got the right kind of fat, but they don't tell you to eat a big sack of them between meals. You see what I'm saying? You understand? Okay, now, so what we have done here
How did I get in here? But that's okay. I'm going to take that, but okay.
Okay, because I'm guilty of this now, because I have made people, we talked about the very bottom of this question on a previous show with a much more, a much different situation. So you'll know what I'm talking about when we start through the graphics here. You have previously discussed my 55-year-old brother in great health. In November of 2020, he had stage 4 rectal cancer with a metastasis to the liver. As you may recall, he had 4 months of chemotherapy, FOLFOX chemotherapy. Then the liver spot was removed and was 100% necrotic and was removed entirely. He had rectal radiation. The rectal lesion was removed in July of 21. So that's 8 months after the liver lesion has been removed. There was still some cancer in a few lymph nodes. Remember that? Then he had a pelvic abscess, which kept him from getting treated. So he had a big block of time between the surgery and his last 2 things of chemotherapy. They ended at Christmas of 2021. Now, interestingly enough, if you just put that together, his survival from November of 20 to to Christmas of 2021 is basically all getting treated. That's 13 months.
Mm-hmm.
But the survival of metastasis, you know, he's pushing that. He's doing very well. Since then, he had radiation cystitis diagnosed in January. He has no rectal issues, but has short bowel syndrome from the surgical removal of the colon, and radiation cystitis is still present. So, here's a guy who had great response to chemotherapy. His liver spot was removed. His rectal cancer was successfully treated. And what he has had was an infection, local infection. That's acceptable. It's common. That's over with. He had a bunch of colon removed, so that has changed the normal bowel function. That's called short bowel, and that means he has a few more bowel movements than he did before. But he's got a sunburn, so to speak, radiation cystitis. Now, this must be bothering him some, but at least it's bothering his brother. You talked about post-radiation hyperbaric oxygen. See, this is where we gave this thing about hyperbaric oxygen. I think people think it's maybe it should be using it more often than he should before. And my brother mentioned this to his doctors. So this guy told his brother, Dr. Whaley talked about radiation therapy hyperbaric oxygen for radiation damage. Remember, that was a big jaw that was in trouble. And the doctor said no for this. What do you think? Well, what's my answer? Well, you know my answer is. Doctor said no. There must be a reason for it. The doctor's probably right. So.
Well, that's what I was going to say. Now, I will say, in all the years we've been together, when a question comes with the doctor recommendation, I don't remember the last time you disagreed with the doctor recommendation wholeheartedly. Now, you might say right. Other options are available.
Correct. You're right.
You know what I'm saying?
Yeah.
But total disagreeing. So let's go with what the doctor said.
That's right. And you'll remember this. Put up this first one, and anybody who really pays attention here is going to remember this is Terrell Owens.
Yes.
Screwing his leg together and getting hyperbaric oxygen so he could get to the Super Bowl, and he played back there in 3 weeks. You remember that? Mm-hmm. And then when we did this the last time, I showed a bunch of pictures of the home hyperbaric oxygen machines that hockey players, basketball players, and football players pay $5,000 for, and some of them sleep in it. And I also said it's not doing them any good, but if it makes them feel good, gives them some, you pull that down now. If it makes them have some emotional thought that they're doing something to make them better on the field, go ahead and do it. But hyperbaric is limited in its utilization, and people would like to use it for lots of stuff. So let's go back to this guy, because he's a great example of aggressive curative intent surgery, as curative intent therapy for advanced cancer, where it's gone from the colon to the liver, and that used to just be a plain old death sentence. You know, I mean, regardless of what we did, it wasn't going to work out well. You might respond for a few years, but there are people that were treated like this man has been treated that are totally cured. So we're going to go back over that. Is that okay? Mm-hmm. All right, good. All right, let's put up that next one. The idea that cancer starts in one place and goes to another. Frequently you think, okay, my wife had breast cancer, and then 3 years later it showed up someplace. So this is what we call synchronous versus metachronous. That's you don't need to remember those, but the definition is that it occurs at the time of the primary cancer or even before. And if it's later, then they're called metachronous. Pull that down. Now, those you don't need to remember those words, but this patient had the liver lesion found at the time of, or actually the rectal lesion was found while they were looking at the liver lesion, so it was there at the same time or slightly before. That is where the curative intent treatment is most effective. If it occurs 3 or 4 years later, then it's probably somewhere else as well. You remember that? Mm-hmm. Okay, so what? Got to throw the algorithm up there for the BKP. We'll look at this quick. But if you've got a limited degree of liver metastases with nothing in the lung or anywhere else within the abdomen, and you go start working through all this stuff here, then this guy got the right treatment, which was systemic chemotherapy first, remove the liver lesion. That gives you a chance to look around the abdomen. If nothing else is seen, then you immediately go to the rectal lesion. It has to get radiated, and then you get it out. Okay, drop that then, okay? So what that has done is this is a survival curve for BKP, right? What this survival curve shows you is those people that have been treated with aggressive therapy, and if you heard there, the liver was totally clear when they removed the liver. If the rectum had been totally clear when they moved it, then that survival curve, this is 5 years way out here, about half of those people are still around without recurrence at 5 years. So you can pull that down. Now, that doesn't mean they're going to stay that way, but at least it is way different than the 2-year survival that would have occurred from a liver metastasis. Are you still with me?
Yes.
You want a little anatomy now?
Just go ahead.
Okay. Got the next one? This is the anatomy of a female. There's the rectum, the bladder, the uterus sits there. So this was a male. Right here where this uterus thing is, right there's a prostate. So when you are radiating rectal cancer, you are radiating the bladder and you're radiating the rectum because that's where the cancer is. And therefore you expect to have rectal issues, which he did, they cleared. You expect to have some bladder issues. You can pull that down now. And during radiation, 100% of the people getting curative intent radiation to the rectum will have some irritative bladder symptoms. Now, they will not all develop radiation cystitis that goes on after it was over. So this is April now, and if we remember this radiation ended about December. So that's less than 6 months ago. Put up that. So here's the story. While you are doing radiation, you get irritation this is called the acute phase, lasts several weeks. The latent phase says months or years. Most people never get this. It ends right in here somewhere. This says several weeks. This says months. So if you get to 2 months after the radiation has ended, there's the radiation ended there, it's my experience that virtually everybody, not everybody, because obviously this guy's not in it, has about finished with their radiation irritative bladder, some bleeding and some discomfort. Now, very few people get out here to the end. This late phase is years. Pull that down. This patient has not reached the years. He's right here in this latent phase. He's just a couple months longer than I would have expected him to have it. So he's got a bladder irritation, which we expect him to have from the anatomy I just showed you. And looking at the time, he's still in that period where it ought to get better. It didn't get better at 2 months, but it ought to get better by 6, 7, or 8 months. It's after it gets to the years that it becomes worse. Now, so here's our radiation cystitis grading system. You don't get to the point where you are grade 4 with a bad contracted bladder that is badly hooked by radiation until a year or longer after radiation has ended. You can pull that one down now. So now we're back to the hyperbaric oxygen. Now, you remember that all the indications for hyperbaric oxygen, you use it when you had carbon monoxide poisoning, and you use it when people been diving and they got the bends and all that. But when you get over here to the medical part, it is for old wounds. Osteoradiation necrosis is bone necrosis from radiation. That was that jaw we had. There are some bad diabetic wounds that could do good for hyperbaric oxygen, and some bone infections. Pull that down. Nowhere in the armamentarium for bladder irritative disease early on or in any of those early stages is hyperbaric oxygen required. Now, get the next one, and this is the end of it here. This is the algorithm for bladder radiation cystitis. This patient, from listening to this, has never gotten to the point where they have put things in his bladder to soothe the radiation damage. Like we put on aloe cream on a sunburn or something. But there are 5 steps. The very end of the very end of that treatment is to remove the bladder, or to divert the urine, because the bladder won't do you any good. And hyperbaric oxygen therapy is a last ditch just before you have to remove the bladder. You can pull that out. So what I would say to this brother here is, one, your brother statistically ought to get better without having to get any sort of surgery or anything. After this has gone on for maybe 6 months, they can put material into the bladder that, by analogy, is putting on aloe on a burn. That should help heal that, and the chances that he'll ever get to having his bladder removed or having to divert the urine out of the bladder or get to hyperbaric oxygen is very small. So stick with what the doctor said.
Stick with what the doctor said. Something about that every time they tell me to stick with what the doctor said. Okay, we're listening to the doctor.
We had a long discussion earlier today about the doctor having certain rules in his office about
Are we going to do Ask the Doc questions or Follow the Rules BKP
No, we're not going to do
Which segment is it?
No,
Follow the Rules BKP?
It's the doctor segment.
Thank you very much, Georgia Cancer Specialist, Northside Hospital Cancer Center.
The guys in the green room have no idea what's going on, do they?
We'll fill them in.
Oh, you going to fill them in? Are you going to tell that story on the television?
No. I did yesterday.
You did?
On my program, yeah. Huh?
We're here for almonds.
They're there for almonds. Okay, let's moving right along.
Did you hear the story about the...
this is not Follow the Rules.
My sister had bad stage 4 cancer of the breast in all of her bones, and was very debilitated and confined to a bed with bone metastasis. She had never had a mammogram and had ignored the lump until it was as large as a grapefruit. Her vertebrae were crushed. That was 3 years ago. And we must have talked about it 3 years ago. We did, I remembered it. Discouraged hospice and said that since she was triple positive, remember triple positive breast cancer? We talked about this patient 3 years ago. Subsequent to that one, we had another triple positive patient a few weeks ago. She should let the doctors treat her with hormones and Herceptin, since she would not consider chemotherapy and she wouldn't need chemotherapy. She did great, had kyphoplasty. That's that stabilizing the bone crushing in the back with silly putty. All of her pain disappeared, and she has been pain-free for 2.5 years. Now, she was going on hospice 3 years ago. In the past 12 weeks, she has had a rapid chest wall mass develop. Her oncologist had a biopsy done because the tumor behavior had changed. So I can see that oncologist saying, look, something's going on rapidly that triple positive breast cancer shouldn't be doing. So let's take another piece of this new tumor and see what's different. But her tumor behavior had changed, and he thought her biopsy also may have changed. Okay, right. That biopsy is now HER2 negative. She was triple positive before. He has suggested chemotherapy for her. She is now 69 years old and has no other health problems. Now, there's a family issue here. I think you better
I'm
remember.
listening to this question very
intensely. You remember this before?
Yeah, I'm listening.
Okay, her husband again suggests hospice. Back at the original one, she was really bad off, and they suggested hospice, and she got better. The husband is suggesting hospice. Now, I don't know why that is, but or even why they put that in the question, but the husband is suggesting hospice. The patient is not, because it now says she is willing to take chemotherapy now, since she did so well before when everybody told her not to take treatment. So I don't know who everybody is, but way back at the start when she was in agony, they told her to go to a hospice, and that must have been family. She got better when she did what the doctor said. Now she's got a recurrence, and the doctor wants to treat her, and somebody's telling her not to take treatment. So we're not going to get into all that psychosocial stuff. But I think that's interesting because there's a lot of that in medicine. As Ray usually says, this is a family, and you've got to try and help them work through those things. Do you think there is anything that could be gained at this time by chemo?
Can I say something?
Yeah, that's your, your program.
Let me say something here from this side before you get into the medical side, because I'm reading the question. Have a personal situation with this going through, with a family going through.
Well, your mother.
Right. I see. Let me say a couple things. I see sister, husband, and the actual patient.
And
okay?
probably more. But yeah.
Right, but that's the
They're
three.
all mentioned.
That's
yeah.
the three in this question. I remember the days when, we would have a discussion, and at the end of the discussion, it's, what does mom want to do? Okay.
You've hit the
now,
nail
now
on
what
the
does
head.
mom want to do? Now, I will say this. Now, my brothers and sisters and I, or several, we talk, we get along for the most part. We are family, so that means every once in a while, right? But for the most part, we talk and we get along. And during this time, it was really good because we really got along, because this is where friction can enter. And my sister would give her opinion, I would give my opinion, my other sister give her opinion. But I have to say to my family that may be watching, at the end, we'd always come back to, okay, I know what you think. I know what you think. What's mom want to do? Let's see what mom wants to do. There was times through mom's chemo that I actually thought I was watching her for the last day.
Right, I remember that.
And getting with my sisters and saying, is she going to take the next treatment? What's mom want? So not to go too long, the end of this is, and here's something I'm seeing for you at home, and not trying to analyze your situation, because it's everyone is personal to the situation. But I'm seeing, if she was pain free, I'm seeing 2.5 years of quality of life. Now, this is where Ray comes in, and Ray will talk about quality of life.
Right.
Right?
Yep.
I'm seeing 2.5 years that it seems as though the sister had good quality of life and you were able to enjoy each other. That's where you're at again.
Right.
Am I correct? Is that's where you're at again? And at the end of the day, if the sister, if the patient wants to do it, I guess the strongest opinion I can say is time to come in and support her.
Right. Now
where was I wrong on that?
No, you're exactly right.
Because I've been listening to you. You always ask me if I listen.
Right, but interestingly, the patient refused chemo when she was really bad off. Right.
Right.
Now that she's seen how cancer treatment works, she's been treated continuously there, and has done well, then she's not as afraid of chemo because she's familiar with the nurses and familiar with the doctors and the procedures, and she's not afraid of it anymore.
So if I'm sitting in your office, and this is you and I, same situation, everything, and I say to you, okay, chemo, talk to me. What's my quality of life? What's my survival curve in this second occurrence? Okay.
Yep.
Explain that all to me.
All right, let's get on it. You ready?
That's what I would be asking, and I know that's what you're ready to do.
All right, hit the big one. All right, so there are guidelines for treatment of HER2-negative breast cancer, which she now has.
Right.
She had positive before. I'm going to explain how that happens. And then with chemo and targeted therapy. She had targeted therapy before. All right, pull out that next one. Remember this is the breakdown. Triple positive breast cancer, that's here, is only 10% of cancers, breast cancers. 73% of breast cancers are HER2 negative and hormone positive. So that's where she is now. She was from a small group, 10% at the original diagnosis, and now she's falling into the biggest group of 73%. All right, pull that one down. There's a little bit of this we'll go through relatively quickly, but her original treatment and the fundamental treatment of HER2 negative patients is to give them chemotherapy, if you'll remember, to get the spot smaller so you can go on and do surgery, so that chemo is done before they even get to the point of having surgery in the normal person. Now, this patient had metastatic disease to start with. All right, pull that down. The HER2 positivity is a good thing. Remember, it used to be a bad thing, right, because it was so aggressive, but now that treatment makes it better. So that triple positive breast cancer has this kind of a survival rate at the top. You got that one up there? And then when that's the triple negative at the bottom. And then in the middle here, you've got the HER2 negative and you've got the estrogen and progesterone receptor positive. Well, they're pretty darn close there, aren't they? So pull that one down. So the outlook of this biological change in her tumor does not mean that she cannot be successfully treated. And those survival curves are very close. She was in the triple positive one. She's dropped into a slightly lower one. Okay, here's the story. Don't use this next one. We'll get rid of that one. This is a pretty one with a bunch of colors on it. So this is a tumor that begins with all one genetics. As you go through these three places and see the bulk of the colors change, that is an untreated tumor. But at the time remember, hers was untreated and it was as big as a grapefruit, right? What they said. So you just imagine this is a small one, a middle-sized one, and a big one, and hers was as big as a grapefruit. So pull that one down. Plus, it was in all of her bones. So what you see in this next picture is the way that over time, still untreated, the tumor biology is overwhelmed by whatever cell has the greatest opportunity to enlarge. Pull that one down. So what you get there is you've got this great big tumor that had all you could see was triple positive. It was treated until the triple positive's all gone, and there's just a few cells that are left at the bottom that started out that were HER2 negative. And when you've gotten rid of the big tumor, they're allowed to grow. And this is the analogy that I use. I want you to imagine you got a garbage can full of black marbles, and then you've got 6 white marbles in the garbage can. So if you just take a scoop and scoop out marbles, it's going to be all black. Well, you just imagine those black marbles are sensitive to the treatment that she got, and the little white marbles down at the bottom were what was left in this 2.5 years that she's been doing good, and they began to grow. Well, that's what has happened to her. So now you just switch gears, give this patient the chemotherapy, which is easy to give now, and she has about an 80% chance that she'll do just like she did before, and that tumor mass will pop up and go away. And then she'll still have hormone positivity. You give her chemotherapy for 3 months, 4 months, and then you can go back to hormonal therapy and probably put her into another remission for several years. So, is there anything to be gained by chemo at this time? And the answer is absolutely yes. She has a real good chance that she can respond. If she responds in a short period of chemo, 2, 4, 6 months, that chemo is going to be stopped, and hormonal therapy can hold her there for a few more years.
Well, let me say this.
Don't be hesitant now.
No, it's 69. She's still young.
Yeah.
Yeah, I mean, no, seriously, she's still young.
I'm 82.
I was getting ready to. I was getting ready to let you say that yourself, but she's still young. That's number one. Now, I want to say something to you, okay? Because the people out there watch every week, and we do have a very big audience for this segment, and they watch you to listen to you break down the answers in these questions, and they listen to Dr. Tidman bring into the general practitioner side of it, and then every once in a while,
gentle guy.
Every once in a while, they listen for me to bring in a question surrounding the other side of this. So here's what I'm going to say to you, because you've done this a couple years.
5, I think.
5, okay? Now, I don't like to say trained. I don't like that, but I'm going to say it. In your profession, the professionals that you are with your team and others out there across the country, you're trained in this. You're trained in the family asking the hard questions. You're prepared for that.
Yeah, you're mostly experienced from doing it. They don't teach you much when you're in training. So you have to learn is on the job.
Right, but what I'm getting ready to say is, I remember, my mom saying to the doctor, my family wants to come with me on this visit. And I remember when we were discussing something like this, this doctor, I'm going to give this guy credit, man. It was awesome, because there was my mother, and there was all of her kids, brother-in-laws, sister-in-laws, and we were all in a room. And that doctor let every one of us ask the hard questions. So my recommendation, and tell me if I'm wrong, ask the hard question. Go into the doctor's office, ask the toughest questions you could think of. That's my opinion. We did that day. Now, I'm just going to speak for personal. We did. My sisters asked very difficult questions to the doctor. What if? What if? My mom said, my kids want to know this and that. And my dad was not available to go. He wasn't able to go. But the doctor answered all of our questions, and welcomed any question we had. What say you when that takes place with you?
All right, let me tell you something. This is my 51st year of practice, and I went into practice to do just exactly what he's saying. Face-to-face with the patient, face-to-face with the family, listen to what they had to say, treat the human being and not the chart. Since March of 2019, that opportunity you don't really have anymore. What they do today, and you can't change it, is that if mom is in the hospital, then they are going to let one person at the most, I don't think 2 could do it, masked, come to the bedside, because it's a little freer now than it was a few months ago. But basically, for a long time, nobody could be in the room with mama when the cancer doctor was in there. They would make a special exception to let one person come in, gowned up and masked, and anybody else had to be present on a cell phone. Thank the goodness we have cell phones. But still today, excuse me, people are pollen's everywhere. You are limited to the number of people that will be allowed in the doctor's office, in the office, or the number of people be allowed in the hospital because of federal CDC rules about COVID and how many people can get there and what they have to do masked up to be there. So I had a conference yesterday with a patient. The oldest daughter was in the room. She happens to be a nurse practitioner in Florida and had come up for this purpose. But the husband was out in the parking lot with, FaceTime. And two other siblings were on FaceTime, how they ever got all those things on FaceTime, on the table there while we had this discussion of patient, daughter, and the rest of the family by electronics. And that isn't the way I would prefer to do it. So
another thing on that, and we'll move from this. Another thing on that also is, I will say to this day, one of the many things I respected from the doctor is all of the difficult questions we were asking. He came back with the difficult answers. It was kind, but it was direct.
Yeah, right.
It is, and we appreciate
around
that.
the bush.
Right,
you
we
can't
appreciate
beat around
that.
the bush. No.
All right, so hey, folks, thank you, Georgia Cancer Specialist, Northside Cancer Institute. What's our news of the day?
Okay, well, I want to emphasize the fact that the positive, I would pull all my videos up, but I won't. The positive rate for COVID testing in Georgia in the last week is 12.2%.
Right.
How many new cases of COVID have there been in Fannin County in the last week?
I don't know, 156?
No, one.
Oh, one. All right, I see 156.
I know, but you're cheating.
No, I'm cheating.
So, and the 7-day moving average is 1 in a week.
All right.
The 7-day moving averages on deaths is 0 in a week. There haven't been a death in Fannin County from COVID, 4 weeks or so, 3 or 4 weeks? The hospitalization rate has gone way the heck down. Death rate's gone way the heck down. The people are taking the masks off to fly in airplanes, but the positivity rate's still up there at 12 to 14%. Remember when it was the first Omicron or the Delta, it had to be below 5% before you weren't just piling up people in the ER.
Right.
So the point is, this disease now is not the COVID of the first 2 years.
Right.
And the public health and the bureaucrats and the stuff are moving slowly to open stuff up. I hope that the federal government's wise enough not to go to court over the face mask in an airplane and so forth, and that's gone. I hope that testing to get on an international flight is gone. My fear is, I don't think it's a fear. I think it's absolute proof positive that in a healthcare situation, in a hospital or a doctor's office, the CDC and the feds will not release that mask mandate anytime soon. So I think you're going to have it off airplanes, off trains. You're not going to be tested anymore to go in a restaurant. Even in California and New York City, you'll be able to go eat in a restaurant without having to bring a daggum COVID passport. I hope you'll see that by summertime. But I bet you in my doctor's office in the hospital, they're going to make people wear a mask, and it's going to go on to the end of this year, if not longer.
All right, folks, Dr. William Whaley asked the doc, Georgia Cancer Specialist, Northside Hospital Cancer Institute. I always wait to make sure the all-star panel is completely assembled before we go to break.
They're still getting makeup, though.
Yeah, they're over there.
They'll finish by the end of
getting their
commercial
nose powdered,
break.
but we got to get you to work.
All right, got it.
We're going to take a break. We'll be back with the all-star political panel.